Hey everybody, my name is Joseph Westner. This is my presentation on the new intervention called TEAM-CBT in treating individuals with SPMI, specifically major depressive disorder, severe recurrent. So to be diagnosed with major depressive disorder, you have to have 5 of the following symptoms at least occurring within a 2-week period, and one of those has to be depressed mood, or loss of interest and pleasure in doing things. So criteria number 1 is depressed mood most of the day, nearly every day, as indicated by self-report or by others noticing. Number 2 is markedly diminished interest or pleasure in all or almost all activities most of the day, nearly every day. Number 3 is significant weight loss when not dieting or when weight gaining, especially like when you're not trying to, and that's considered 5% of your body weight in a month, either increasing or decreasing, or decrease and increase in appetite nearly every day. And criteria number 4 is insomnia or hypersomnia. Hypersomnia is sleeping excessively. That'd be like more than like 10 to 12 hours a day. Criteria number 5 is psychomotor agitation or retardation nearly every day, observable by others, or, well, I guess this one's not self-reported. So yeah, it's people noticing that you're moving like so slow that it's noticeable. Number 6 is fatigue or loss of energy nearly every day. Number 7 is feelings of worthlessness or excessive or inappropriate guilt nearly every day. Number 8 is diminished ability to think or concentrate or indecisiveness nearly every day, either subjective or observed by others. Number 9 is recurrent thoughts of death, not just a fear of dying, but suicidal ideation without a plan or having suicide attempts. So that's classification A. Classification B is the symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. So it affects you going to work, it affects your social relationships, homework, those kind of things. It makes it so you're not able to do those things. Number C is it's not attributed to psychological effects of substances or a medical condition. And D is at least one of the major depressive episodes is not better explained by schizoaffective disorder, schizophrenia, schizophreniform disorder, or delusional disorder. And also, there's no presence of a episode of mania or hypomania, because then you'd be diagnosed with bipolar disorder. So what makes it severe is if the number of the symptoms is substantially in excess of 5, and the intensity of symptoms is seriously distressing and unmanageable. And it really interferes with your social and occupational functioning. That's why it would be considered a severe and persistent mental illness. And then what makes it recurrent is that for major depressive disorder, it's kind of a short window. It's only 2 weeks long. So you would meet those symptoms, be free of those symptoms, and then after 2 months, meet them again. It's different than persistent depressive disorder, which is also in the DSM-5, which is like major depressive disorder, except it's more mild and it's continuous. The requirement for that is like within a 2-year period. So this is my client, Roberta Shiftke. She's 28 years old. She's a white single female. Was first diagnosed with major depression when she was 15 years old. Just background history related to her mental illness. Client's father was an alcoholic, and the client's mother was hospitalized multiple times for suicide attempts. The client has had 3 periods of homelessness in her past, but currently resides in a mental health supportive living apartment. The client has had trouble keeping a job because she lacks the motivation to get out of bed sometimes, so she'll call into work, or she'll just not show up to work and not call in. The client has persistent thoughts of ending her life, but has never made an attempt, and this has been present ever since she was 15. Client has had trouble with addiction in the past, specifically with alcohol and marijuana, but currently has a year and a half of sobriety. Client was physically abused by her father in the forms of physical beatings, not any sexual abuse. The client is attending weekly individual therapy, but does not think treatment will be successful because she's been in treatment since she was 15 and hasn't really recovered since then. She's still dealing with the same stuff. That's why we're going to try a different kind of therapy for her that hopefully will be more effective. She's also been on medications, which have helped in the past, but the gains were not kept. Like, it would work for a little while and then just stop working. So the prevalence of major depressive disorder is, within a year, someone reporting it is 7%, and this was in the DSM-5 TR, which I believe the survey was taken in 2002. Etiology, or like the cause of depression, there is no concrete evidence for what causes depression. A framework is the stress diathesis model, which basically says there are genetic factors. If your parents had depression, you're more likely to have depression. And then stressful life events can bring it out. And if you're more genetically predisposed to depression, you're more likely to get it when something stressful happens. In my client's case, it was a difficult childhood, physical abuse,